joint webinar on the very hot topic nowadays, pre-rheumatoid, exploring the dilemma to treat or not to treat. And I'm Magda Osipian from Armenia, Yerevan. I'm clinical rheumatologist and also a member of Visibility and Global Affairs subcommittees. And it is my honor today to moderate this webinar with Hanna Solano. Hanna, can I ask you to introduce yourself?
Thank you very much, Magda. Hello, everyone. I am Hanna Soliano, a clinical rheumatologist as well, based in Manila in the Philippines. And I am also part of the AYR board, the APLAR Young Rheumatologists Board. I am very excited to co-chair today's event with Magda here. And the speakers and the members of the EMEUNET and AYR have prepared long and hard for this, and we can't wait to get this debate started.
Thank you, Hanna. We and all our team really hope that this webinar will spread some light on the questionable aspect of rheumatoid arthritis. And before the main presentations, we will ask you to answer these questions about pre-rheumatoid arthritis, because your opinion is really very important for us and our team. So please, you have 1 minute to vote the questions. Crystal, can I ask you to share the screen? And before you can see the questions, and I will introduce our speakers for today. And please meet Victoria Consent. Victoria is an internal medicine resident at Medical University of Vienna. And simultaneously, she is doing her PhD in medical informatics and biostatistics. She's also a member of newsletter subcommittee of EMEUNET. So please meet Victoria. Hanna, can I ask you to introduce our next speaker?
Yes, thank you, Magda. Our next speaker is Dr. Xu Chuanghui, a consultant in the Department of Rheumatology, Allergy, and Immunology at Tan Tock Seng Hospital, Singapore. He is actively involved in the national and international scientific community. He contributes as a member of the APLAR Rheumatoid Arthritis Special Interest Group and the AYR board as well. During his rheumatology training, he was acknowledged with the National Outstanding Clinician Scientist Resident Award from the National Medical Research Council. His main research interest is in rheumatoid arthritis.
Thank you very much. I really hope that we'll have very interesting webinar and very interesting presentations. And before the main presentations, we'll have briefly presentations about main organizers of our webinar, EMEUNET and AYR. And please meet Diego Benavent, who is a chair-elect of EMEUNET, and he is a consultant rheumatologist at Hospital Universitari de Bellvitge in Barcelona. So we'll ask Diego to briefly make a briefly introduction about EMEUNET. Diego?
Thank you very much, Magda, for this introduction. I will just wanted to take some minutes to introduce everyone about EMEUNET. Actually, just coming from the American College of Rheumatology Congress, I reflected on the experience I had last year on the ACR EULAR APLAR exchange, in which I could meet some members of AYR, and I really reflected on the meaning of being a member of EMEUNET, of what EMEUNET entails to do. Basically, EMEUNET is an organization that was founded almost 15 years ago by Daniel Aletaja, Lord Gosek, and Maya Butch, with 3 clear objectives of promoting education among emerging rheumatologists and researchers in rheumatology, also to promote their collaborations in research and in clinical practice and facilitate their integration into EULAR activities. And this has evolved up to being today an EULAR committee, of an EULAR representation committee formed by more than 3,000 members, and developing their activities by the EMEUNET subcommittee and the EMEUNET committee. Here I wanted to introduce you a little bit the people that are making this possible, who are the different members of the subcommittee and the committee that is divided into different aspects, such as education, peer mentoring, social media, country liaisons, visibility and global affairs, and newsletters. And here you see the main leads that take the lead in conducting all of these activities with the work of a wonderful group, which is the EMEUNET subcommittee. The EMEUNET subcommittee members who make it possible to have very interesting and engaging activities, such as being able to participate in the EULAR task force. For each EULAR task force, there are at least 2 EMEUNET members collaborating. Also, we have different peer mentoring activities, such as mentor-mentee meetings in every Congress, or participating in different postdoc mentoring or mentoring activities. We promote the things we do in the different social media. We have an incredible network around Europe, which is the country liaisons, which had one representative per country to promote different activities, such as one that we are creating for the next EULAR, which is RheumaVision. Visibility and Global Affairs Subcommittee is in charge of developing joint activities with different organizations, such as developing this wonderful webinar, and also get in charge of having networking events in the Congress, among other activities. And of course, we have the newsletter subcommittee, who takes the lead on having one monthly newsletter on different topics. Here you have a small hint of what the country liaisons networks is, that I think is a good example of the different collaborations in EMEUNET. And here you have some of the activities that took place in the last EULAR Congress in Vienna, that you see, for example, that there were networking events, country liaisons meetings, that there were a meeting with a group of patients, and there were different sessions moderated by EMEUNET. Similarly, in the ACR, we had a EMEUNET committee and subcommittee meetings, and we have meetings with the ACR members. We had time to develop the networking event, and we had a newsletter before and after the ACR. We are proud of developing activities such as this that I think are at the core of EMEUNET, developing webinars, developing initiatives with other groups such as AYR, I think gets everyone involved and engaged with EMEUNET and also with different organizations. So that's why I'm very proud to be here and will like to share with all of you the activities that we do, and to engage with us in social media, and to offer the opportunity for all the members of AYR to become a member of the spread community of EMEUNET that we are growing more and more every year in every way. In summary, getting every day in every way better and better. Thank you for your attention.
Thank you very much, Diego. It is truly an honor to be collaborating with you in this event, and we are looking forward to future events with you. Now, to introduce the AYR, it is my pleasure to introduce Dr. Gita Harifi. Dr. Harifi is a rheumatologist based in Dubai and one of our leading experts in musculoskeletal ultrasonography, and she'll be introducing what the APLAR Young Rheumatologists are all about. Gita?
Yes, we cannot hear you, Gita.
It's myself. Thank you, Hannah, for the nice introduction. It gives me great pleasure to take part in this joint webinar with EMEUNET. The essence of our collaboration is to be indeed collaborating with similar groups all over the world, and EMEUNET is definitely one of the first groups that we were aiming to work with. So this is a very little introduction, very brief introduction of AYR. AYR stands for APLAR Young Rheumatologists. And to tell you who we are, I think that we define ourselves as a community for informists, and a community usually is defined by shared attributes such as geography and language, culture, but it's also, and what defines a community is that sense of belonging and that strong and deep drive to contribute meaningfully for to the community. So we came together since 2017 with a vision, a common mission.
Sorry. Yeah, Gita, just your screen, if you want to share it, you are able to do it.
I actually thought I have shared the screen.
Now you are sharing.
You can,
Yes.
okay, sorry. I thought that it was.
Okay.
So AYR, as I was saying, is a community with some commonalities, obviously, with the members, such as geography, language, and culture. But it's also a place where a bunch of people came together to work together with a very strong sense of belonging to an institution called APLAR, which is the League for Rheumatology Associations in the Asia Pacific region. I like to introduce us as a community with a common vision, a mission, and a strong drive to contribute towards APLAR. So the purpose of APLAR Young Rheumatologists is to provide a conducive and nurturing environment for APLAR trainees and for young rheumatologists from the region. We define young rheumatologists as rheumatologists below 45-year-old. I think that we can be young and beautiful above 45, but we had to put a limit, and it was initially 40-year-old, and so it was modified later on. And so we provide the idea is to provide a network for collaboration in different aspects, in research, in education, and in social activities. One of the objectives is also to encourage active participations in all activities of the main body of APLAR, APLAR Congress, APLAR Academy, and APLAR SIGs, which cover most of the areas of interest and special area of interests. But it's also the vision was also to identify and nurture future leaders of APLAR, and I guess in EMEUNET this vision is also there. The leaders of EMEUNET today are probably the future leaders of EULAR. So AYR aims to get people together for research networking, for education and improving, and giving a platform for education throughout the region and beyond. But it also oversees and all networking at an international level. We do have obviously subcommittee that look into the drive of membership, and we started a project of AYR ambassadors 2 years ago to increase the membership drive. So this was the beginning. This was the start in Dubai in 2017. This is where it all started when YK, that you can see in the middle of the picture, from Singapore, who is the godfather of this institution, came and presented the project of this young rheumatologists group. And in 2018, we had the first meeting, and we started the membership drive from there. That was in Taiwan. And then every year during the APLAR Congress, the AYR had a networking event and also, an AYR symposium, besides some preceptorship, training offered to our community. So here we are in 2024. We are 13 board members. We count 33 AYR ambassadors from all over Asia Pacific. The mission of these ambassadors is for and foremost to increase the drive for membership, and also to serve as and to improve the communication with the following and the respective MNOs. We are now, we count around 2,000 members today, and we're aiming to hit the number of 3,000 soon. These are the members of the AYR board in 2014, and as you can see, we cover the whole a very vast and large area in the Asia Pacific. And this is the map of the ambassadors. We have 33 ambassadors from different countries, members of APLAR. And I'll end with this small video, sorry, from AYR. Thank you very much.
Thank you, Gita, for your presentations. And now let's start and move on to the main presentations. And Victoria will share her opinion about pre-rheumatoid arthritis with the topic pre-rheumatoid arthritis. It is better to treat on this stage. Victoria, please.
Thank you very much, Magda. Can you see my screen?
Yes.
Great.
Yes.
So thank you, first, of course, for inviting me to give this talk, and thank you very much for organizing this webinar. It's great to see these joint efforts and these introductions of EMEUNET and young AYR were very interesting as well. So pre-RA, I mean, this is really on vogue. I don't know, any of you had attended a conference in the past 2 or 3 years and has heard a lot about this topic. And I'm going to talk a bit in favor of treating pre-RA, or what could speak in favor of treating pre-RA, but of course this is very highly debated, and I'll be also looking forward to hear a debate on that later on. When talking about why we should treat pre-RA, I just try to go to the next slide. These are my disclosures. Okay, so when talking about why we should treat pre-RA, the first thing that we always hear, or I think the most important argument, is always this window of opportunity. So a period in the progression of the chronic disease where we can kind of intercept the disease progression. So we can see that here on this slide from a recent review by Stenenberg and colleagues. This is a kind of the natural course of the progression in red here, and in this window of opportunity, we hypothesize to kind of either suppress disease onset, so really delay the onset of RA, progression towards RA, or even prevent. This would of course be ideal, prevent the disease onset.
Sorry, Victoria, can we ask you to speak a bit louder?
Oh yeah, of course, I didn't know. Do you
Thank
hear
you.
me properly?
Yes.
I'll try to keep it loud. Great. Okay, so we what was I saying? Okay, this here now is the left, on the left is this slide again. And what you can see here on the right now are scenarios that we kind of try to approach when treating RA. So here is what we're currently doing. We're treating RA and, well, trying to prevent the progression of the disease or treat the disease. In an ideal scenario, we treat the pre-RA period and then prevent or suppress disease onset. But what kind of be the worst case scenario is to treat and not be effective in treating or preventing pre-RA, and then really to treat early, so have adverse effects and costs and whatever, and not really have an effect in the end on the pre-RA period. So what is it? What does it look like when we talk about pre-RA? This is the APLAR positive kind of scenario. So you all of course know that we're treating, so differentiating in APLAR and positive and negative patients. Also rheumatoid factors play a role. So you always have a genetic predisposition of pre-RA patients. And we kind of take it, so we have got some environmental risk factors, epigenetics, then it's going towards smoking, stress, and whatever. And then in the APLAR positive patients, we're also talking about autoimmune features, so formation of APLARs and rheumatoid IgM antibodies that then drive kind of the progression, or might drive the progression towards the RA phenotype. So we're then talking about the clinical suspect ultra-alpha. I'll come to that in a minute. Progressing towards the rheumatoid arthritis. So what are now the most important risk factors or prodromy of pre-RA? Just to give you a brief context on that. I've been mentioning the autoantibodies, the ACPAs and the rheuma factors, of course. Then there is this clinical suspect arthralgia. What is clinical suspect arthralgia? I'll come to that in a minute, but it's a phenotype of arthralgia, and that has been defined. And then there is subclinical findings on MRI or on ultrasound or other imaging modalities to be complete that of course indicate or are very close to the progression towards a real RA then. So in 2017, EULAR set out to define these arthralgia suspicious of progression towards rheumatoid. Of course, there are many reasons why one has arthralgia or joint pain. And what is very important about this definition now is that we have an entry criterion. So you usually, or you always have to look at the patients and first check this entry criterion. So patients with arthralgia without clinical arthritis can only be evaluated in that context. So arthritis onset is kind of the border that we take towards the real RA disease then. So joint symptoms of recent onset, so below than 1 year, MCP involvement, and there's this morning stiffness, so this inflammatory phenotype that gets better throughout the day. Then they bring in again the genetics, so first degree relatives, and of course they bring in also physical examination. So there's this fist making test. So for example, in our department, we've got this device where patients kind of make a fist, and we measure the force of their fist making. And if that goes down in the pre-RA period, we're always kind of alert or getting alert whether there is a progression in the disease. Okay, then as soon as patients develop arthritis, so really joint inflammation, synovitis, as soon as you can see, feel that in the physical examination, we're talking about rheumatoid arthritis, and this is the 2010 ACI EULAR classification criteria. You're of course all familiar with those, but again, like I said, you need the clinical manifest synovitis or arthritis, and it is currently not recommended by EULAR or ACR to treat arthralgia without clinical arthritis. Okay, this is now, I think, a very important slide when we are talking about the pre-RA period. Because what you see on the upper side is, again, the risk factors or the stages from a pathophysiologic point of view, with the genetic risk factors, then the autoimmunity, and then progressing towards the rheumatoid. And below you see the clinical phenotypes the patients have. So the healthy patients, those with the clinical suspect arthralgia, and those with the arthritis. And when we talk about pre-RA studies, we've got some really high quality trials that were highly published in the past few years. And we have to always be aware that these study different populations. So pre-RA was heterogeneously defined across the past years. So for example, what you see here, I will come to the trials later, but there are trials that studied APLAR positive patients without arthralgia. There were trials that studied symptoms without, so the clinical suspect arthralgia phenotype with or without APLAR formation. And then there were studies that included patients that already had subclinical findings on MRI or ultrasound. So these were further or later in the disease stage than, for example, the patients that were included in the other trials, like the PRAIRIE or the STOP-RA trial. So always keep that in mind when you interpret these studies, because I think we're discussing about these studies a lot, and just keep in mind what populations we're looking at and what outcomes we then kind of interpret or measure in these patients. So this is now an overview, and I'm sorry for this kind of overloaded slide, but I'll guide you through that very quickly. I mean, we've got in fact six studies, 6 randomized studies that we should know, or that everyone should know when talking about the pre-RA period. And the compounds that were studied, we studied dexamethasone, we studied rituximab, methotrexate, hydroxychloroquine, so the conventional synthetics, and then we studied abatacept. You see that here. So these trials, keep them in mind. So, and then looking at the results now, we see that at least for the glucocorticoids and the conventionals, we did not have a significant benefit in the primary endpoint, so the progression towards RA. So these were all kind of negative studies, at least concerning the primary endpoints. What we saw now, and what I think was of course highly discussed or shown at the last conference were these abatacept studies. So the ARIA and the APLAR study, abatacept for 6 and 12 months, that showed a significant benefit in the progression towards RA. And I'd like to guide you through those two trials quickly, because there are some things that we need to consider when interpreting the results. So APLAR, this was the first study that was published, or the second, I think, was published. So they were kind of published at the same time. This is patients with clinical suspect arthralgia. They were either rheumatoid factor and APLAR positive or APLAR high positive, but they didn't have any current arthritis, of course, and they were also DMARD negative. These are the baseline characteristics. This is a bit small, but it is also not so relevant to look at area aspect. What I would like to show you here is the autoantibody formation. So most of the patients were APLAR and rheumatoid factor positive, and they had, of course, no swollen joints, but they had some tender joints, some patient global evaluator global evaluation, and also pain. And what you see when you look at the ranges in baseline characteristics was that those were kind of broad, so there were patients without major symptoms and some with a high burden of disease already. This are the results now, or this is the main figure of the trial. I think most of you are familiar with that, and also the fact that abatacept delayed the onset of rheumatoid arthritis. So you see that here, the curves diverging, but also that after we stopped treatment with abatacept, so we treated for 12 months here. This was on the left hand of this graph, and on the right hand side, you see that the curves start to emerge again. The same goes for ARIA. This is abatacept in subclinical arthritis. So these were patients that already had imaging findings on MRI. So they had evidence of synovitis, tenosynovitis, or osteitis on MRI ultrasounds. And what you see here again now is that abatacept really delayed progression towards rheumatoid arthritis, but then again, curves started to kind of get closer together again in the second period. So after we stopped the treatment and only did an observation period. Okay, so now I've been introducing these two trials, and I mean, I've also introduced briefly some negative studies. And now my talk should be in favor of treating pre-RA. And this data, I think, is very interesting and is also very positive in that sense. So we can maybe delay the onset of RA. We don't know if we can, what the long-term outcomes of the patients in these trials will be. But what would maybe speak in favor of treating pre-RA? Or let's put it differently. EULAR, of course, puts out guidelines to treat rheumatoid, and they say we should not treat patients before they really have arthritis because we don't have significant evidence that this is a benefit. But then this is how guidelines diverge, I think, a bit from clinical practice, because in clinical practice, I don't know what it is like with you, but I always see some patients where we say, okay, they've got the rheumatoid factor, they've got, or the APLAR, they've got the suspicious phenotype, and we're kind of sure that they will progress towards rheumatoid. And should we then wait, I don't know, for another 4 to 5 months until they develop really the synovitis, or should we give them maybe the methotrexate straight away? So I think this is kind of a question that we are asking ourselves, at least in Vienna sometimes. And this is now where Joseph Small's definition of disease modification comes in my sense. So disease modification, what this task force defined in 2020, is of course the prevention of clinical arthritis or the modification of progression or structural damage. But then there is also this reduction of disease burden in at-risk patients. So for example, also arthralgia and fatigue. And when you look at the secondary endpoints of the pre-RA trials, I think it is still kind of interesting that we did see some benefits both on subclinical information, for example, in the methotrexate studies, or the Treat Earlier trial. And also what I want to show you here on the right-hand side is that in Treat Earlier, patients really show the benefit in subjective symptoms, functional ability, workability. So this is a post-hoc analysis, I'll guide you through that was published very recently in ARD. This is a cost-effectiveness analysis actually of the Treat Earlier study, where they looked at these patients with subclinical arthritis. Again, remember, these were patients in Treat Earlier that already had findings on MRI. or ultrasound, so subclinical arthritis, and they treated them with methotrexate for 1 year. And they saw, for example, that these patients, you can see that here in the mean days among those with productivity loss, the patients, both those that developed RA in the end and those that did not develop RA, so the whole cohort really had benefits concerning subclinical information, physical function, pain, morning stiffness, and absenteeism, presenteeism at work. So what the authors concluded in that analysis was that pre-RA treatment was cost effective and the patients were actually better, so that you might potentially treat these subclinical information and benefits, and then patients could benefit from that. This was very recently published or shown at ACR in Washington, ACR conference. And I wanted to also show that to you today, because this is another postdoc analysis of the Treat Earlier study, so methotrexate in early RA. And this is the last study that I want to show you today. But the reason why I picked it is again a postdoc analysis. And what they did here was they kind of sliced the Treat Earlier population into APLAR positive and APLAR negative patients. So they had both included in their trial. And then they again sliced these APLAR negative patients into high risk and low risk patients. So high risk of progressing towards rheumatoid and low risk of progressing towards rheumatoid. And what they could show is that in APLAR negative patients with a high risk of progressing towards rheumatoid, methotrexate did have a significant benefit. The reason why I showed it to you is that for once it is interesting, of course, hypothesis generating, and that's the only data we have for APLAR negative patients. But of course, in addition to that, I always have, I think we also have to be aware that these are all only postdoc analysis. So this is data that is, we often do this with these randomized trials. We slice the data and we slice it again, and then we get a significant result. So what I want to say with that, these are interesting hypotheses, and we of course look at this and interpret and maybe investigate further in prospective trials. But these studies or postdoc analysis are not powered to take firm conclusions on these results. Okay, so to summarize, we are still quite unsure actually when to start treatment. I do think that there might be benefits in individual patients of treating before they really have clinical arthritis, but it's very hard to show in randomized trials because you need very long-term data. But I think that these postdoc analyses concerning subjective or patient-reported outcomes are very interesting. In fact, we don't know which therapies we should use. So we have positive data for abatacept, but not very promising data for conventionals or also rituximab. And then one question that is for sure important is, what are the aims of pre-RA treatment? So are we really aiming to prevent onset of rheumatoid arthritis, or really heal kind of the disease in a window of opportunity? Is this potentially possible, or can we at least treat some symptoms or delay the onset of the disease? Just very briefly again, this is what I always, I think, introduced into every presentation in the past few years, because I think it is very important nowadays, talking about these kinds of context of treatment strategies in rheumatoid and psoriatic and in other diseases. In guidelines, we really need firm evidence that work for everyone and are safe for everyone. But in clinical practice, it's more of matching a patient profile with the drug efficacy and safety profile and bringing that together to really get the individual patient to benefit and have better quality of life, health-related quality of life is what we should, I think, aim at. And it sums up to giving the right treatment to the right patient at the right time. And with that, I'd like to thank you and send you some greetings from Vienna, which is a bit more cloudy today, actually, but we have very nice Christmas markets going on. And I'll be very much looking forward to the next presentation. Thank you.
Thank you very much, Victoria. Those are some very interesting points and very, very well discussed. Thank you very much. But now let us move on to the counter argument that in pre-RA, maybe treatment might not be necessary. So, Xuanhui, please take it away.
Can you see my slides and can hear me well?
Yes,
Great,
sir.
yeah.
Yes.
Thank you for inviting me to join this interesting webinar. So it's really my pleasure. And it's a hot topic and a lot of, I fully agree with Victoria, a lot of controversy, and that's why we have a debate here. What Victoria shared was really informative and insightful. So I would share my opinion from my stand. So my stand is there's no need for treatment at present. I have nothing to discuss. So this is the most recent EULAR recommendations. I believe everyone are familiar with this one. So in this recommendation, it mentioned the definition of pre-RA is debatable. It's a field of research with too many uncertainties. And in this most recent guideline, it was proposed in this research agenda for pre-RA. So what is the optimal therapeutic approach to arthralgia suspicious for progression to RA? So apparently, according to the most international guideline, there's no recommendation to treat pre-RA. Of course, my debate will not stop here. So let's go on and examine why I would stand this opinion. So Victoria share details of the different phase of the RA. So we're all familiar with and we are also comfortable with treating with established RA or early RA. So if patients have clinical synovitis, I think no doubt they will benefit from treatment. But what about the clinical stage of rheumatoid arthritis? Regardless whether they have the symptom or not have symptom, here is the stage we have a lot of controversy. So today we are talking about pre-RA, focusing on this stage when before patient developing clinical synovitis. So I have 4 reasons to say there's no evidence or there's no need for treatment, at least at the present. So the risk of pre-RA evolving to clinical RA is not high. We need to consider the benefits and risk when intervening with the pharmacological treatment. And there's no proven preventive window of opportunity. I think this is fundamental. Last one, there's a potential safer non-pharmacological interventions. So these are 4 reasons I would say there's no evidence to support or treat pre-RA at a stage. So first of all, how is the risk of pre-RA evolving to clinical RA? So we have the benefits of the most recent publications. This is the data from UK prospective cohort study. They recruit 90 patients. All the patients they have the ultrasound subclinical synovitis, CCV positive, and has musculoskeletal symptoms. So most of the time today for the clinical trial, these are considered high risk. They are trying to enrich with this population to increase the power of the trial. So we can see how the outcome for this prospective cohort. So within 1 year, about half of the patients actually self-resolved. I mean, of the subclinical synovitis without any demands. And even among the rest of half, I mean, about 43% actually did not evolve to a clinical synovitis. So if we are starting treatment for this population, I mean, considered to be a high risk of progression to RA according to the most recent trial or our definition now, a lot of patients will subject to for over treatment. Are they really happy with it? I mean, our healthcare able to afford the burden of treating for such kind of population? So I think the answer is clear. So first, I think the risk of progression from this population to clinical arthritis actually is not high. Second, there's a lot of trials, as Victoria elaborate, and we do need to consider the benefits and risk of the pharmacological treatment. So this is a brief summary I did. So Victoria mentioned quite detailed and give very informative, comprehensive summary. So as she mentioned, most of the trial actually the results are negative. So the steroids, rituximab, atorvastatin, methotrexate, hydroxychloroquine trial actually was prematurely stopped because of the futility of the study. So all these trials are negative. The only excitement comes from the most recent publications for abalaceptor. So there are some positive results, I mean, no doubt. But I will examine later why I still would not advocate for treatment, even there is evidence from these 2 trials. So treated earlier trial using methotrexate is very interesting study. Victoria put some quite a comprehensive view for this trial. So 2 years ago, it was published in the Lancet. The results was negative, so overall was negative. And in the CCP positive high-risk population also was negative. And in the subgroup analysis, CCP negative or positive, there's no difference. And 4 years later, I have to really applaud the authors' efforts to perform the further study. So they did a 4 years follow-up. So again, the overall, there's no difference. And among the patients with CCP positive with high risk, also no difference. And they found a difference there's within the population, the subset of the patients who were CCP negative with high risk of the developing RA. This algorithm was based on the same group they developed in their own cohort. They used a few parameters to calculate the predicted risk of developing RA from this cohort. And among the CCP negative patients, with low risk, the results were negative. So this finding actually in this CCP negative subgroup was rather interesting, and it's a kind of thought provoking. So, but we really needed to examine very carefully for these results. So as Victoria also mentioned, it's a post-hoc analysis. There's no, I mean, the subgroup analysis. So many group was negative, only one group was positive, so really subject for the multiple test risk. And if we examine carefully, actually the two arms are not balanced. So in the placebo arm, actually there are more patients with positive RF, and there are more patients with extensor tenosynovitis. So of course, this population, they will inflate the results in the placebo arm, they will develop more rheumatoid arthritis. So it's not fair, I mean, we then compare the unbalanced arms. And as we all know, the seronegative RA actually quite heterogeneous, and the diagnosis is challenging sometimes. And the pathogenesis also not very as clear as CCP positive cases. So again, CCP negative in this subgroup actually is not really seronegative. So if we examine carefully, they put this in their supplementary table. So this is seronegative subgroup with high risk of developing RA. This results is negative. So this means all the subgroup analysis was negative except one subgroup, which was a CCP negative with high risk of developing RA. So I mean, this result is quite interesting and it's thought-provoking. It is only results for the CCP negative RA, but we need to be very carefully interpret the results. We definitely need a more well-designed, controlled study to perform to validate the results. So the benefits actually is a bit doubtful, but the risk and burden is obvious. Let's take the best results from the abalacept trial, the AYR trial. So in this trial, it's considered results is positive, and the absolute risk reduction is about 22%. What does this mean? This means about 78 patients actually are overtreated. This is not the patients having a cancer, they have imminent mortality. So this is a patient with evolving to rheumatoid arthritis. So really, we are really subject to this 78% patients for risk of overtreatment. I think we need to be careful with this. And another thing is use of the healthcare resource. So for all the clinical trials and the clinical practice, when patients do not have clinical synovitis, often we probably were using the radiological evidence to see whether there's subclinical synovitis or not. One is the ultrasound. So do we really have the expertise and the resource to screen the patients for this population? I think the availability is quite low. As we all know, the training for MSUS actually is take quite a long time. And second thing is the MRI screening. If you practice in public hospital as I do, we all know the resource of MRI screening is quite limited. A lot of patients with stroke or some urgent needs, they're queuing for the MRI screen. So MRI scanning. So are we really using the MRI screen for the patients with high risk of RA to subject them for the treatment? Again, there's a caveat of the MRI screen. So there's high false positivity in the general population. So last but not least, if we treat too early, it will cause a huge psychological distress and healthcare burden. Particularly where we're using abatacept, which use only positive results for the RCT so far. Are the patients, physicians, and the stakeholders going to accept the burden from the biologics to treat pre-IA patients? I think the answer is obvious. So the third reason I would not advocate for treating pre-IA is there's no proven preventive window or opportunity. I think this is most important and it's fundamental. So why do I say so? So actually, there's in the community, actually, it's recognized, it's only presumed, but has not yet been proven. So this very nice graph, Victoria also shared this graph. So ideally, when we treat with patients at this stage, we can prevent the RA, but obviously this not happen. A lot of patients actually recurred, but less ideally, it's still acceptable. When it was treated in the early stage, actually can prevent the onset of arthritis, probably not as severe as untreated population. But the worst scenario is if we treat it and subject patients with the risk of the over-treatment and increase the burden for the society and individuals, yet the patients, the onset of arthritis rebound as severe as untreated patients. So this is the worst scenario. So which trajectory our patients will follow if they receive the treatment? Let's have a look at the results, the evidence. So this is the results from the methotrexate and rituximab. Here you can see once they are on the treatment, there is some signal to show the delayed onset of arthritis. I think this is no doubt. And once they stop the medication, the two lines merged. So it means this purely delayed onset of arthritis rather than preventing the onset of arthritis. So you may argue the most recent data from the abatacept trial show the benefits and positive signals, but let's look carefully. So after stopping the abatacept, the onset of arthritis actually quickly catch up with the placebo arm. Although after the end of the study of 18 months, there's still statistical significance, but actually the two line actually is merging. So imagine, if they follow up longer, beyond 18 months, which is usually they do for other trials, I think the two line likely will be merged and the effect of the abatacept probably will be diminished. So again, these results also consistent. The hepatitis, the treatment using abatacept, the very strong immunosuppressive is only delayed onset arthritis rather than preventing the arthritis. So again, the APLAR trial using the abatacept, similarly the trend we can see from these two arms. And more importantly, if we stop the abatacept, the function, the quality of life, actually no difference. So you can see clearly the two lines merged. So if you recall the trajectory of the disease I just showed you, this meaning after rebound recurrence of arthritis, actually the severity is similar. There's no difference. They're not less severe than the untreated arm. So this means actually the rebound recurrence of arthritis, they will reach as severe as untreated population. So in this article, actually the author also acknowledged the effect of the 12 months of abatacept treatment are not sustained. So let's come back to this line. So obviously all the patients treating with a pre-RA are not following this line. They're not going to prevent. And very likely, probably they will follow this line. As we can see from last slide, the rebound or recurrence of arthritis, actually, the quality of life, the pain, actually, they are as bad as the untreated arm, although they were delayed. So we definitely need more evidence to show the window of, the preventive window of opportunity. So this is fundamental and the most important when we consider to treat RA. And why so? Are we targeting the right time? I think the concept Victoria mentioned is, I fully agree, is we should treat a patient at the right time with the right treatment for the right patient. But are we, all the trial are conducted now at the right time? Why all the trial are turning the negative results, even the positive results actually was not really satisfying. So there's some studies show actually at the stage of the patient with positive serology with some arthralgia, the disease actually is matured. It's not going to be reversed or prevented. So this study showed the autoantibody maturation. So you can see from here, there's no difference in terms of the level or the variety of the CCP autoantibody between the two groups, namely the patient progress or not progress to inflammatory arthritis. There's no difference. So this indicates the disease at this stage actually is matured already. And if we target this stage, we're probably not going to prevent the disease. We are just delay the onset of arthritis. So here we are facing a dilemma here. So if we are treating here with the patient with arthralgia before onset of arthritis, probably it's too late, and we are not going to prevent the disease. But if we move forward, if we treat too early, obviously there's a risk of the overtreatment, and we broaden the indication of treatment and increase a burden for the individuals and society, which is really challenging now for most of the healthcare system. So how to resolve this dilemma? So I think there are some potential safer non-pharmacological interventions available nowadays. So this is a recent study from US. They examined the US nursing cohort. So they found the risk of the incident are actually reduced if they have the higher score of healthy lifestyle index. So actually it's dose dependent, as you can see from here. The more they have the lifestyle index, the more benefits they have to reduce the incidence of RA. So I think this is really important to advocate patients to stop smoking, control the weight, and exercise, and so on. Not only for RA, I think generally, I think for the general health is also important. So this is quite feasible and practical in our practice. Second, this is the vital trial results. Again, this is the post-hoc analysis. I would emphasize the caution interpretation. So you can see from here, the vitamin D arm actually reduced the onset of autoimmune disease by 22%. So this is quite interesting, and vitamin D actually is quite a safe and easy drug to prescribe. Of course, this is a post-hoc analysis and need more prospective pre-specified design RCT to validate the results. Recently, we performed a study in the NetX. It's a global database involving multiple academic centers. So we examined the impact of the influenza vaccine for the onset of rheumatoid arthritis. So we screened the patients with a high risk of developing RA, namely the patients with positive serology or rheumatoid factor or CCP. The arm receiving influenza vaccine actually significantly reduced the risk of onset of RA compared to the arm who never received influenza vaccine. So I think this is also feasible, and it's practical in our practice. Of course, this is an observational study, and it's a retrospective study. Definitely a lot of confounders. We will need more data to validate the results. So in summary, these are 4 reasons I would say at this stage, we do not have evidence to support the treatment for a pre-RA now. And we need to be very mindful to consider this. As a physician, I think the first principle is do no harm. Do not overtreat the patients for this population. And often less is more. We as a physician often attempt to mitigate the risk without considering how small or unlikely the potential benefits, and try to fix a problem rather than monitor and cope with it. Prefer to act quickly rather than waiting for more information. And we often prefer a newer treatment such as abatacept or biologics over the old treatment. So we need to be very mindful for this, especially in the context of increasing healthcare burden in most society and the aging population in most society. So we need to be very careful. And after all, the recommendation not only based on RCT, not only based on evidence, we have to balance the benefits and the risk, and we had to take into account patients' value and preference. Very importantly, we had to consider the available source in the society. So in summary, at present, I would not favor to treat a patient with a pre-RA at this stage. Thank you. That's my summary. Thank you so much.
Thank you, Chuan Hui, for your excellent presentations. And now we're ready for a discussion, and we'll have a question in the chat box. Please, if there are any questions from our audience, you can just ask them with unmuting your microphone, or just write them in the chat box. And the first question from the chat box is the role of the treatment of periodontitis. So, Victoria, Chuan Hui.
Yeah, you mean related, for example, to aqua formation potentially, and also goes into the direction of smoking, these interventions. I think I'll let Chuan Hui maybe discuss, because you mentioned the non-pharmacological interventions of pre-RA. Maybe you came across this when you did this research.
Sure, yeah. Yeah, actually, I think there's a role of treatment of periodontitis. Actually, the oral health is very important. There's more study of the microbiome now. I mean, how the oral microbiome initiated the disease and play important role in the pathogenesis of rheumatoid arthritis. So the treatment for the periodontitis is very important, especially in the pre-RA. And I think it's not only for the RA, also for the cardiovascular health and general health. So it's quite important and feasible. I would advocate for this approach.
Okay, thank you. We have also one more question about the diet, how diet influences the progression of AYR. So you both could answer.
Yes. I mean, there's been some studies, but the problem is this is really hard to study. First of all, dietary interventions always have a high dropout and then kind of confounding rate. Second, again, what population do you define? Kind of. I don't know that, also I don't know of any high quality, like randomized or larger study that really studied, for example, Mediterranean diets in pre-RA patients, like a population that we saw for the APLAR or the Treat Earlier study. So I don't know of any trial like that exists. There's of course some retrospective analysis, some smaller studies also in manifest arthritis, but they all did not really show very consistent positive results, because I think it's very, very hard to draw conclusions from dietary studies. But the conclusion, I think, in the overall community is Mediterranean diets, healthy diets, for sure make sense and do not harm anyone. Yeah, but it's very hard to prove.
Yeah,
Chuan
I
Hui,
agree
do you
with
have anything to add?
Yeah, I agree with Victoria. I think there's no solid data to recommend that influence for prevent RA. But actually now there's some basic research or animal research. The short-chain fatty acids actually some benefits for preventing or even treat for clinical RA. So for example, the butyrate, they have the anti-inflammatory effect. So in the animal model, they see the benefits to prevent or even treat clinical arthritis. So I think there's a potential have the direct influence to prevent clinical RA. But this again need more solid evidence and a large populational study.
Okay.
Thank you. Yes. Dr. Babur Salim, I think you're raising your hand, and do you have a question?
Yeah, thank you. Thank you very much. Thank you, Victoria, and thank you, Shu. Excellent presentations. Just a comment. I was just thinking that aren't we running too fast, directly targeting the treatment? We still don't have any recommendations and guidelines to how to make the diagnosis of, can you hear me, please?
Yes.
Sorry.
Yes.
How to make the diagnosis of pre-RA. I think that we need some recommendations that whom to screen first. And once what are the steps to make the diagnosis? Should we go serial ultrasounds? Should we whom to screen for an MRI? I think that this is probably, it's just a comment that I think that we need to go first on the investigations. And once we know that these are the patients who are at high risk, and what are the methods to screen these patients, specifically using an ultrasound or maybe an MRI. And once we know that this is the cohort which is at very high risk, and then maybe we can think about the treatment. What your take or your comments on it? Thank you.
Yes.
Maybe I can
Chun Hui,
first.
please. Yeah.
Yeah. Hi, Babu. I fully agree with you. I mean, the definition of pre-IA, as I mentioned, Victoria also shared, actually, it's also area of research, and there are a lot of debates and controversy. To my opinion, actually, pre-IA is a continuum of disease, not like a one stage or one time point. So it could be at the stage with the patients with a genetic risk when they develop the positive autoimmunity, and then the stage of the arthralgia. So there are different stages. So the fundamental and important tool we need to develop now is the prediction model to predict who will evolve to RA. As I showed from the UK prospective study, even the factor we are commonly used now, as you also shared, I mean the radiological synovitis by ultrasound MRI, actually is not very specific. You can see from the UK prospective data, half of the patients with ultrasound positive synovitis, they self-resolved. So we really need a good tool to predict the patients, enrich the patients who warrant treatment. And again, the tool need to be very practical and readily available. Ultrasound MRI actually is quite a high resource cost. So I think it's important to study a different stage and develop a tool to predict the risk of developing RA. That's an important area for research.
Okay, thank you. Crystal, can you go ahead?
Yes, first, I wanted to thank all the speakers for their excellent talks. And really, as the EMEUNET subcommittee chair of the Visibility and Global Affairs, I'm really happy for all this collaboration with AYR. And I wanted to actually ask a small question about the application of what we saw today. So it's important actually to a bit see what we usually do in clinical practice. So many of you sometimes come see some patients with a clinically suspected arthralgia and patient with inflammatory arthralgia. However, on physical exam, you don't really have these real synovitis. However, for example, in my practice, I usually go and always do an ultrasound, and sometimes I find these synovial hypertrophy without activity on the Doppler ultrasound. So it's a sort of maybe synovitis, but that is not very active. So in those cases, it's a bit subclinical synovitis. So how would you approach a patient like this? So it's a patient who really has inflammatory pain without any clinically synovitis. Would you go and treat him? Would you consider him as a pre-RA or a subclinical phase where you wouldn't treat a patient like this?
Yeah, thank you very much, Gisela. And I think this really breaks it down to the point that we're now, or the discussions that we're really facing in clinical practice. You've got this period, these patients, you know that there's something going on, you don't know what. But you think, should we wait for it to kind of show its face, or should we just treat, I don't know, with methotrexate or whatever? And we have actually been studying these patients and are still doing in RA and PSA. And we had this one study where we could show that these tender non-swollen joints in ultrasound that have kind of any signal in ultrasound, but especially Doppler, will progress towards RA. But the Doppler was really the most important risk factors. And what we don't know yet, and what we really didn't solve yet, is how to really treat these non-inflammatory lesions in ultrasound. So these, because we see them a lot in the PSA cohort, in the PSA at risk cohort that we now have. So we built up this cohort, and we see a lot of patients that have these clinical suspect arthralgia phenotype, and they just see kind of some grayscale signal, not really a Doppler. And well, we don't know yet, but we're really trying to find out, because this is a really landmark, I think, currently in clinical practice. But the Doppler is, I think, very indicative of progression.
Yes.
Yeah, I may add a little bit. Yeah, so I think that now there are two prediction models. One is developed from Leiden Clinic, and another one from UK data, as I just shared. I think the Doppler signal not necessarily predicted the evolve of RA, but actually the intensity of the Doppler signal and the location of the Doppler signal matters. For example, if there's a multiple joint and with a high Doppler signal, I think it probably predicted the high risk of evolving to RA. This was observed from the Leiden clinic and the UK data. And I think in the audience also mentioned about the extensor synovitis, if you know, or tenosynovitis. Yes. Yeah, I think the extensor tenosynovitis is also important to predict the evolving of clinical arthritis. So there are a few factors as Victoria shared, actually we have to individualize the patients and look at the different parameters, for example, how intense the Doppler signal and how many sites involved and how the ESR and whether there's extensor tenosynovitis or not. We take all these parameters, then we can decide to start treatment or not one parameter.
Okay, thank you very much. I think we have time for a few more questions. We have one question in the chat box from what about patients presenting with tenosynovitis without arthritis and with negative serology? Would they be classified as seronegative RA or preclinical RA? Victoria, would you have an opinion about this?
Well, I think more of PSA actually, but tenosynovitis, I don't know. No, I mean, we cannot, we don't know. This comes down to what Barbara also said before. We have a very heterogeneous definition of these undifferentiated arthritis periods, but well, I don't know. We should really go down to defining these very, very homogeneously, but we didn't do it yet.
Yes, completely agree. Chun-Hui, any comments on this?
Yeah, I really agree with Victoria. Yeah, it's very hard to differentiate at this stage.
Okay, and maybe one last question. Is there any study stratifying the risk for developing established RA based on these types of patients that we have?
You mean the study differentiating, you mean prediction models or?
Yes.
I don't know of any, I don't know if you know, Chun-Hui, of any really prediction model.
I know you mentioned the prediction tool for predictor what patient will evolve to RA.
The Leiden.
The Leiden, I think the data from Leiden clinic, the treat earlier RA trial. So the group actually developed one algorithm. So they will take into account several parameters. For example, how many location of Doppler ultrasound was partial and the titer of the CCP and the ESR. I can't remember details. So the algorithm they developed. That's why they conducted this post hoc analysis in the treat earlier trial using methotrexate. This is one algorithm. Another algorithm is from the UK perspective data just now I shared. So they observed actually half the population actually self-resolved. But among the population who evolved RA, they tend to have more Doppler signals and more sites joint involved, and the titer of CCP also positive. So generally, these are parameters they are looking at. But I think they need to fine-tuning this tool, the model.
Yeah, just maybe a short comment on prediction models, because we will see lots of those in the next few years. And the problem is that they are fitted to the data that, of course, they were designed in. So they are usually overfitted in the populations where they were conducted, and we'll have to maybe come towards a period where we'll put out and really publish also the models, like the code, for example, the data, and then really try to validate it in other cohorts. And like Chun-Hui is saying, fine-tune these models. So the ideal scenario in the future will be to kind of publish our models that we derive from our data, and then get other people to not create their own model, but just validate or fine-tune the model in their data. And then we'll maybe come towards more applicable predictions. But I think it's really difficult to get these suspicions that we have from clinical practice. So we have these feelings of phenotypes or subtypes of patients or at-risk patients really into statistical models. because these are always have to be applicable for kind of everyone, or at least 59% of the people, and this makes it very difficult, I think.
Okay, so because of the time, the last question from the Lawrence Duquesne.
Oh, hi. Thank you very much for to give me some time. I just wanted to actually jump on what was just discussed here about prediction model. Indeed, like how the population needs to be like homogenized, and how prediction models tend to be a bit overfitted to the population it was based on. I think like there was one prediction rule developed by Amsterdam in 2012 that was very interesting, but then also the UK published another score last year on CCP positive arthralgia, but then it's a different population than CSA. It's not the one you mentioned, it's the one from Annals of Internal Medicine, and obviously still need external validation, but then nowadays there's lots of action that can be done trying not to overfit the data. So I think it's quite interesting to see what will develop in the future. Thank you.
Okay, thank you very much. I think that is all the time we have for today. But as we close, we started the day with a question that gave two different answers, but I think we can end it agreeing that more research needs to be done on the topics. We are very fortunate to be in the age of modern medicine, and we have lots of ways to do research now that are more advanced, and we can all definitely look forward to more updates on this topic for the years to come. Thank you very much again to our speakers, Victoria and Chuanhui. Excellent presentations and discussions. Thank you very, very much. Thank you again to the members of EMEUNET and AYR for all the help in organizing this event. And of course, to our lovely audience, thank you so much for taking the time to be with us today from every part of the world. And this has definitely been a very exciting and engaging afternoon, evening, or morning, depending on where you are. And we hope to see you in our next endeavor. Thank you again very much.